I'm Pat Garrity, an instructor of medical laboratory technology.
And I'm Jerry Walters, supervisor of a hematology laboratory. The purpose of this video is to help you bring body fluid analysis into the 21st century.
Jerry and I will cover the material for this video presentation in 3 sections. The first section will cover the basics, the second will be on microscopic observations, and the third will be on cell counting. You will note on the video cassette case the times for each section are listed, so if you choose to skip ahead or review the material a second time, you'll easily be able to find the topic you're interested in. A handout has been supplied with this video. We will refer to it frequently, so you may want to have it handy as you view this tape. The first section will be a quick review of the background information about the various body fluids analyzed in the hematology laboratory. The fluids which we will discuss are from the central nervous system, cerebral spinal fluid, the pleural and abdominal cavity, serous fluid, and the synovial space, synovial fluid.
Cerebral spinal fluid has 3 primary functions. It protects the brain and central nervous system from sudden changes in pressure and pH. It maintains a stable chemical environment, and it removes metabolic waste products. In current practice, there are 4 legitimate reasons to test cerebral spinal fluid: to detect meningitis, to detect a subarachnoid hemorrhage, to detect the presence of malignant cells, and this includes leukemic cells, and lastly, to diagnose demyelinating disease such as MS. This last reason to test CSF typically does not involve the hematology laboratory, so we will not be discussing it. A common difficulty in cerebral spinal fluid testing is differentiating a traumatic tap from a subarachnoid hemorrhage. Since it's been said that close to 20% of the spinal taps performed are traumatic, this is not an infrequent occurrence. There are several ways to help differentiate a traumatic tap from a subarachnoid hemorrhage. First, since CSF is usually and preferably collected in 3 or 4 sequential tubes, you can often visibly see the difference. In a traumatic tap, there will be decreasing amounts of blood as the tubes are collected. The last tube obtained will have significantly less blood than the first tube obtained.
In a subarachnoid hemorrhage, equal amounts of blood are seen from the first tube through the last one obtained.
If clotting has occurred in any of the tubes, it is evidence of a traumatic tap.
With a subarachnoid hemorrhage, there will be no clot formation in the tube. The physiology of this is a little confusing. The fibrinolytic system has been activated in vivo, and so the fluid obtained no longer has the coagulation factors necessary to form a clot in vitro. A positive D-dimer test is a better confirmation of this process.
The D-dimer test will be negative in a traumatic tap since there are no breakdown products of the fibrinolytic system. If the blood present is due to a traumatic tap, the supernatant will be clear after centrifugation of the sample.
From our schooling, we all remember a xanthochromic supernatant is a hallmark of a subarachnoid hemorrhage. The presence of a blood-tinged supernatant is due to the breakdown of red blood cells within the central nervous system. A microscopic observation also found in CSF from patients with a subarachnoid hemorrhage is the presence of hemosiderin and hematoidin. This again reflects the breakdown of red blood cells within the central nervous system. We will show you this finding in the second section of this video.
Of course, the possibility always exists that you may have a traumatic tap superimposed on a subarachnoid hemorrhage. Then you're sort of out of luck. It's going to be difficult, if not impossible, to tell the difference.
The next fluid we want to spend a few minutes on is serous fluid. Serous fluid is from the pleural, peritoneal, or pericardial cavities. Its function is to lubricate. The reasons for testing these fluids are to detect sepsis, to detect a malignancy, or to detect systemic disease.
Serous fluids have traditionally been separated into transudates and exudates for diagnostic purposes. The criteria that's used currently for this separation is listed in your documentation manual. We're not going to discuss them here, but you will notice if you read them that some of the historic criteria we use, such as the white cell count and the specific gravity, are no longer used due to their poor sensitivity and specificity. We will spend a moment, however, on the formation of serous fluid, specifically in the pleural cavity. This is a schematic of the pleural space, which is actually a potential space. There is just enough fluid to provide lubrication between 2 pleural membranes. Fluid is constantly filtered through the parietal pleura and reabsorbed through the visceral pleura. This constant filtration and reabsorption is a function of differences in pressure on either side of the membranes and the integrity of the membrane itself. Disorders which disrupt this balance of filtration and reabsorption are listed in your manual. The most common cause of a pleural effusion is congestive heart failure. Other diseases such as pneumonia or a malignancy damage the membrane itself, allowing a leakage of protein and a resultant buildup of fluid.
Other serous fluids we should mention are those formed in the abdominal cavity and pericardial space. The mechanism for the abnormal accumulation of abdominal fluid is similar to pleural fluid formation. Fluid accumulation in the pericardial space is a rare occurrence. Another fluid we now frequently analyze in hematology is dialysate fluid from patients on peritoneal dialysis. The primary reason the fluid is tested is for the detection of infection. In fact, up to 70% of the dialysis patients experience an infection within the first year of treatment. A WBC count of greater than 100 with more than 50% PMNs is considered suspicious for infection.
The last category of fluids we'll cover are the synovial fluids. The green areas on these schematics indicate some of the synovial spaces we are familiar with. The hips on the left are Pat's, and the hips on the right are mine. As you can see, mine will last a lot longer because they are far more substantial.
Yeah, but I do better at parades, I can see.
Yeah, but probably over time you're going to get short too. Because of its thick and goopy nature, synovial fluid is an excellent lubricant. It also provides nutrients to the joint, and it removes waste products. Examination of synovial fluid is performed to detect sepsis, to detect a hemorrhage, or to diagnose crystal-induced inflammation.
Based on hematologic findings, synovial fluids are divided into 4 diagnostic groups. These are Group 1, non-inflammatory, Group 2, inflammatory, Group 3, infectious, and Group 4, hemorrhagic. For a further description of these groups, refer to the handout. Because synovial fluid is so viscous from the hyaluronic acid present, it is sometimes very difficult to get a reliable cell count. Prior to cell counting, we recommend the use of hyaluronidase, an enzyme that digests hyaluronic acid. The procedure for this is in your manual. As an introduction to the second and third section, we would like to briefly discuss general specimen handling.
Before we get into the nitty-gritty of cell counting and identification, we need to talk a little bit about the body fluid specimens because they cannot be handled as routinely as a peripheral blood specimen. These are truly one-time specimens. Other than CSF, these spaces do not normally have an appreciable amount of fluid. So once you draw the fluid off the knee or out of the pleural space, you cannot go back and get some more until the body makes some more. So we have to be a little more tolerant in the laboratory. Do not reject the sample just because the label is on inside out or the first name is misspelled. We certainly do not advocate guessing at whose sample is whose, but make every effort to track it back to the source and get positive identification. Trust me, if I had had a spinal tap and they told me the laboratory would not test it because it wasn't properly labeled, I would not be my normally pleasant self.
Pleasant?
Yeah, pleasant, goddammit. The same is true for clotted samples. Do not unilaterally reject them. I think we sometimes take great glee in the laboratory in saying, aha, it's clotted, can't do anything. You can do something. You can look for bacteria or malignant cells. These are significant findings. You can give an approximate cell count. A few cells or a lot of cells is useful information. Take the clot or fibrin strands or whatever out with a clean applicator stick and process the sample the best you can. Make sure you indicate on the report that the results are approximate because the sample was clotted. If you receive a sample with insufficient volume for all of the testing ordered, don't just pick the easy ones to do. Ask the physician to prioritize the testing so that you do the important ones first before you run out of sample.
Quality slide preparation is really important for body fluids since the microscopic observations are so critical. There are two ways to make slides. The first, and definitely recommended way, is to use a cytocentrifuge. This type of instrumentation concentrates the specimen better than the second way, which is manual concentration using a regular centrifuge. With either method, it is recommended to use 1 drop of 22% albumin. By using albumin, the cells stay intact. The slides should be stained with right stain. It is important that all supplies, especially albumin, are not contaminated, which can interfere with observing bacteria.
We're going to look at microscopic findings that are either specific for a particular fluid or are of diagnostic importance. We won't be covering the normal hematopoietic blood cells, and we'll start with CSF. One type of cell that you may see on rare occasions, specifically in cerebrospinal fluid, are ventricular lining cells. Other terms used for these cells are choroidal ependymal or neuroectodermal cells. It is not important to be able to put an exact name on them. What is important is that you recognize them as ventricular lining cells, which are not diagnostically important, and don't confuse them with clusters of malignant cells. Other findings that are certainly not limited to, but are more significant in cerebrospinal fluid, are erythrophagocytosis and hemosiderin or hematoidin crystals. Erythrophagocytosis, which you see here, is simply a phagocytic cell that has engulfed red blood cells. This is evidence of a subarachnoid bleed, as is hemosiderin and hematoidin crystals, which you see here. The black stuff is the hemosiderin, and the yellow crystalline structure is the hematoidin. These are further breakdown products of the red blood cells.
In this next slide, you can see many PMNs. What is of even more importance is the intracellular bacteria. Remember, I said previously that the right stain must be uncontaminated to be assured that the bacteria is really from the fluid. But in this case, who cares? Because the bacteria is intracellular, which has nothing to do with the quality of your stain. If the bacteria were only seen extracellularly, then the reagents would have to be evaluated. Another difficulty in observing bacteria is the presence of precipitated stain on the slide. This next slide is of right-stained Cryptococcus. You will note the sunburst-like effect, which is a hallmark for this organism. Because we are seeing more immunocompromised patients, the presence of Cryptococcus is not an unusual finding anymore. These are leukemic blasts. The presence of any leukemic cells in the CSF is important since it is an indication that the leukemia is not under control. Without cytocentrifuge concentration of the specimen, these cells may be missed if they are present only in very low numbers. That is why Jerry and I so strongly recommend the use of the cytocentrifuge. It is unbelievable how many more cells are harvested using this instrument rather than using the manual concentration method. These are malignant cells, in fact, adenocarcinoma cells. The presence of these cells most frequently indicate metastasis of an already diagnosed malignancy. Just as with the leukemic cells, the use of the cytocentrifuge is critical.
Some of the significant microscopic findings in serous fluids include bacteria. This pleural fluid has increased neutrophils and a pretty obvious chain of rods, but we need to stress again, if you see only extracellular bacteria, you have to be sure it is not contamination. The purple inclusions in these neutrophils are yeast found in a pleural fluid. Yeast can be seen in other fluids, but is more commonly seen in the serous fluids. These opportunistic infections are often seen in immunocompromised patients.
This is an LE cell from a pleural fluid. Unlike peripheral blood, LE cells form in vivo in pleural and abdominal fluid. These cells are usually seen in persons previously diagnosed with lupus. There are also some PMNs seen. Along with a lot of PMNs, 3 macrophages can be seen in this slide. Macrophages, which are tissue monocytes, are regularly seen in serous fluids. We recommend calling these cells mononuclear phagocytes, grouping them with other phagocytic cells, such as these 2 histiocytes seen here, along with some other cells that we will discuss later. The two histiocytes are a type of tissue cell frequently seen in serous fluids. In the center of this slide is a signet ring. The magnification of this slide is less than what we have been viewing, so you can more easily see the structure. This is really nothing more than a vacuolated histiocyte that has had its nucleus pushed to one side by the large vacuole, giving it an appearance of a signet ring. In the olden days, which Jerry and I are all too familiar with,
Excuse me?
these cells were considered an indication of malignancy, but really they're not. Some institutions prefer to report these as a completely separate cell type, even though they are of little diagnostic significance.
One of the difficulties of serous fluid examination is the differentiation between mesothelial cells and malignant cells. This is especially true if the mesothelial cells have sloughed off the lining of the pleural membrane in sheets or clusters. So we're going to spend a little time on the differences between the two. Sometimes it is very easy to tell them apart, and sometimes it's not so easy. Before we begin looking at the photomicrographs, we're going to go through some of the most common characteristics of both types of cells. But remember, there are very few absolutes in life, and exceptions there are many. Mesothelial cells have distinguishable cell borders when they occur in clumps or clusters. The clusters or clumps are flat sheets of cells, not ball-like.
In malignant cells, the cell borders are poorly defined. Frequently, the cells are in clumps appearing ball-like or three-dimensional.
Mesothelial cells are individual cells. They may be large, but not giant, and tend to be uniform in size.
In malignant cells, often there are cells within cells. This is called cannibalism. Another common finding is the non-uniform and often monstrous or bizarre appearance of the cells.
Mesothelial cells have a low nuclear to cytoplasmic ratio and a smooth nuclear membrane with even chromatin.
Malignant cells usually have a high NC ratio with an irregular nuclear membrane with uneven chromatin.
Mesothelial cell nuclei are round or oval with no clefts or folds. They may be multinucleated, but the nuclei are uniform in appearance.
With malignant cells, there are frequently multinucleated forms with very varied nuclear sizes. Nuclear clefts can be present. The nuclei sometimes form a mosaic pattern referred to as nuclear molding.
Mesothelial cells may be vacuolated, but the vacuoles are restricted to the cytoplasm.
In malignant cells, the vacuoles are also over the nucleus.
Now let's look at some cells. This is a bird's eye view of a couple of mesothelial cells. They have a smooth, uniform appearance. These are malignant cells. These are easy ones. They are giant and non-uniform. This is another view of mesothelial cells. They have an even chromatin pattern and again look fairly uniform. These are malignant cells in a three-dimensional ball-like cluster.
In this slide, there are a few mesothelial cells. The binucleated one is not an unusual finding. The nuclei of all these mesothelial cells are similar in size and appearance. This is a good example of cannibalism. Remember, this is seen in malignant cells. This is another binucleated mesothelial cell. Sometimes these are described as having a fried egg appearance. Here's another example of cannibalism. You can certainly see the difference between this and the mesothelial cells from the previous slide. Instead of being separate and distinct, these cells are cells within cells.
These mesothelial cells have vacuolated cytoplasm, but notice the nuclei still have a smooth, uniform pattern. These malignant cells are also vacuolated, but the vacuoles are all over. They are not uniform appearing cells. These again are mesothelial cells, uniform and little variation in size. They have debris in them, but mesothelial cells can be phagocytic. These are malignant cells. One of them certainly qualifies as a monster cell. They are very non-uniform.
Again, another binucleated mesothelial cell, but what I want to talk about in this photomicrograph is the necrobiotic cell. This cell should not be confused with an NRBC. It is nothing more than a dead cell. Again, these are malignant. One of the cells has engulfed cellular material. We saw this slide previously when we were talking about histiocytes. Also present on this slide is a mesothelial cell, which looks a little different from the ones we have seen previously. The nucleus meets the criteria for mesothelial cells. The cytoplasm, however, is a darker blue at the periphery. This cell would be considered somewhat reactive. Again, mesothelial cells with similar nuclear size and appearance, but the cytoplasm is somewhat reactive.
These are malignant cells. These are a little more difficult. They are all individual cells, but the vacuoles are all over, and look at the nuclei. The nuclei are not uniform or smooth. This is a reactive mesothelial cell. Reactive cells are often a deeper blue, and the color alone can make you think they are malignant. These are, well, what do you think they are? They look somewhat uniform, but we can't really see individual cell borders, and the chromatin pattern doesn't look quite right. We think these are suspicious, and whenever the cells look suspicious, you get to pass it off on the pathologist. No, seriously, you can't always be sure, and when you're not sure, the sample should be referred for further review or cytology. These cells fall into the same category. They don't look real awful, but have a non-uniform appearance. That makes them suspicious.
Now we're going to view photomicrographs from synovial fluid. On this slide, we see synovial cells. These cells have an appearance similar to mesothelial cells, but since there is no such thing as mesothelial cells in the synovial cavity, the identification of synovial cells is not difficult. This is a higher magnification of a synovial cell. Remember, they cannot be mesothelial cells and should be reported as synovial cells.
Joint fluid exams are often done to diagnose crystal-induced inflammation. These are the group 2 fluids. To do an adequate job on crystal exams, you need a polarizing filter and a red compensating filter. This will help you differentiate between monosodium urate or uric acid crystals and calcium pyrophosphate crystals. And why would you want to do that? Because the cause and treatment are different. Uric acid crystals are seen in gout, while calcium pyrophosphate crystals are seen in a disorder called pseudogout, or not really gout. Crystal exams should be performed on wet preps as well as stain smears before treatment with hyaluronidase. And be especially careful about your stain because the least little bit of moisture will instantly dissolve uric acid crystals. These are monosodium urate crystals under polarized light. The needle shape is characteristic, but they may be very small. These are urate crystals viewed with a red compensating filter. Urates are yellow when their long axis is parallel to the direction of the red compensating filter. They will be blue when they are perpendicular. These are calcium pyrophosphate crystals, and they show the opposite reaction using the red compensating filter. Blue when parallel and yellow when perpendicular. Calcium pyrophosphate crystals usually have a chunky, almost square appearance. An artifact or contaminant you might see when doing crystal exams are these, talc crystals. It's a good idea to use powderless gloves when you're looking for crystals. And this last slide is something I think we may start to see more frequently. These pleomorphic blue things are debris, polyethylene or plastic pieces from an artificial knee joint which is failing.
This section will be on cell counting. Before we begin to actually talk about cell counting, we would like to discuss a couple of things. Red blood cell counts on body fluids are of little diagnostic value except for cerebral spinal fluids. For CSF, a red blood cell count should be performed. When cell counts are ordered on other body fluids, only a nucleated cell count should be performed. This is an important concept. In the past, we would refer to this count as a white blood cell count. But now that we have seen all the various types of nucleated cells present in fluids, it's easy to understand why the count is not a white blood cell count, but a total nucleated cell count, and it should be reported as such. To count cells on body fluids, we all have performed manual cell counts, it seems forever. In your handout are some guidelines for making dilutions and for the areas of the hemocytometer to count. Since we are all familiar with manual cell counting, we refer you to the handout. Cell counts on hematology instrumentation is a newer concept which we will spend time on. In today's world, the more we can automate, the safer it is for laboratory workers, since so often these fluids are serious biohazards. Before implementing automated cell counting in your facility, there are certain things needed to be considered. The 3 Ds: what to do, document, and decide.
Before you can even consider automating your body fluids, you need an instrument that provides some kind of picture, a histogram or scattergram, to help you interpret results, and an instrument that can maintain a low background, preferably 0. Next, you need to evaluate your background. It will make a difference if your instrument reports your white blood cell counts to 1 or 2 decimal places. If your analyzer reports 0.0 for a background, this probably means you have less than 50 particles. But 48 or 50 particles are significant when you are doing very low cell count body fluids. This will limit your lower linearity, because at 0.1 you may have anywhere from 50 to 150 particles. If your analyzer reports 0.00 for a background, you can be pretty sure you have less than 5 or 6 particles. So at a count of 0.01, you may have 6 to 14 particles, which will have little effect even on low cell count fluids.
Another important to-do is to be able to interpret histograms or scattergrams generated on automated instrumentation. We are going to show you important areas of these pictures to view on both instruments that generate 3-part diffs and those that generate 5-part diffs. We are only going to be talking about the total nucleated cell count, not the differential generated on the instrumentation. Nucleated cells in body fluids will not separate the same way whole blood cells do, so the differential should not be used. The first example is generated on an instrument which gives a 3-part diff. This WBC count would be acceptable to use as a total nucleated cell count because the histogram looks acceptable. The same criteria for acceptability you use when running blood samples should be used when doing body fluid counts. The curve begins at baseline and also returns to baseline, indicating no interference. The red blood cell count would be acceptable if one were needed. The red blood cell count would be 50,000. Remember, red blood cell counts are only important for cerebral spinal fluid. The platelet histogram should be reviewed, since white blood cell debris will be seen in this channel.
This histogram from the same 3-part analyzer shows an unacceptable WBC histogram. There is interference which causes what we call a high takeoff. The histogram does not begin at baseline. This would not be an acceptable count on peripheral blood, so it is not acceptable on a fluid. The right side of the curve also shows an abnormality. The curve does not return to baseline but rises. This is often an indication of very large cells or clusters of cells frequently associated with a malignancy. Remember the monstrous and ball-like clusters of malignant cells? The red cell histogram shows interference on the left-hand side of the curve and does not begin at baseline. If this were a cerebral spinal fluid, this red cell count would not be acceptable. The platelet curve actually looks okay, but with so few red cells, it is unlikely to have 70,000 platelets. This is more likely cell debris or whatever is causing the interference on the other parameters.
Here is an example of a printout from an instrument that performs a 5-part differential. Remember, all we're interested in is the total nucleated cell count. This total nucleated cell count would be acceptable to use. Both the scatter and the histogram show no evidence of interference. Looking at the scatter plot, the discriminator line indicates clear separation of cells from debris. On the histogram, the discriminator again indicates clean separation of cells from debris. If this fluid were from a CSF, the red blood cell count would be acceptable. The platelet channel shows no interference.
This example on the same 5-part analyzer shows an unacceptable result. The discriminator on the scattergram shows obvious interference, and there is no clear separation between what may be debris and what may be cells. The histogram display reflects this interference. The discriminator shift due to the interference is significant. On this type of instrument, clumps or clusters of cells and giant cells will appear in the upper right area of the scattergram, as well as the far right slope of the histogram. The red cell histogram shows significant interference, and if this were a cerebral spinal fluid again, the result would not be acceptable. The platelet curve shows either a lot of platelets or a lot of debris. It is highly unlikely you would have 1.5 million platelets with few red cells. This scenario is often seen when the nucleated cells have degenerated, either because the fluid was collected over time in a bedside drainage bag or the specimen took the scenic route to your laboratory. The degenerated cells are now pieces of cells and have moved towards the debris area of the scattergram. These fragments are small enough to appear in the platelet channel. This is probably a good time to point out why body fluid specimens should be processed quickly. Cells degenerate more rapidly in body fluids because they are not in their normal plasma medium. In CSF, you can lose up to 30% of the neutrophils in 1 hour and 50% in 2 hours.
On this printout, from another instrument that performs 5-part diffs, the white blood cell count is performed in a channel separate from where the differential is performed. Because of this, the histogram, which is a picture of what is happening in the counting channel, must be evaluated. The histogram shows no interference, beginning and ending at baseline, so the WBC count would be acceptable to use as the total nucleated cell count. The scatter plot, which is not as helpful but should be viewed, does not show increased thickening of this line. Since red blood cell and platelet technology is the same on these instruments, there is no need to continue to show these parameters.
This is an example of an unacceptable result on this instrument. The scatter displays show changes, but where you really need to look is at the WBC histogram. It does not begin at baseline and has an extremely high takeoff due to some kind of interference. The histograms and scattergrams we've shown you are examples. You need to know how to interpret the pictures on your instrument to know when your result is acceptable or not. You need to especially look at discriminators or zones that separate things that may be cells from things that are not cells.
The next thing to do is to perform precision and correlation studies to see if you can implement automation into your laboratory. Included in the handout are documentation forms to use as you gather the information. You should do precision studies on your instrument following the same method you use for doing precision with whole blood. Also, for fun, you can do precision of the manual method. It may be a real eye-opener to see the results. You also need to do correlation studies between instrument counts and manual counts.
You need to document your results since you are performing a new application on your cell counter. Plot your results on the graphs we have provided. Naturally, you are not going to plot the unacceptable results, but do keep the printouts of the scattergrams or histograms for your comparison studies. You need documented evidence that your instrument will show you when a result is unacceptable. If you visually examine the graphs, you will get some sense of whether you can automate. If you choose to use a statistical tool, be aware that correlation coefficients do not work well when you are dealing with very low cell counts. One of the paired test statistical tools should be used instead.
Once you have gathered all the information and looked at all the documentation, you need to decide what you can automate. Depending on your background and how the WBC is reported, may limit the lower linearity or lower reporting range. But even if you can only automate samples with total nucleated cell counts above 1,000 will be helpful. Another thing that must be done is to set up an ongoing evaluation of your upper linearity limit. As your laboratory processes fluids with high total nucleated cell counts, the upper reportable range can be adjusted.
This is not a difficult process. You're already doing the hard part, the manual hemocytometer count. Just zip the same fluid through your cell counter and save the results. Besides, cell counters today cost a lot of money. They ought to be able to count cells. We want to thank you for watching this video. We hope we didn't put you to sleep. We also hope the information was useful, and we wish you success in automating your body fluids. Say goodnight, Pat.
Good night, Pat.
Very good.